Good afternoon, everyone. My name is Darius Means, and I want to welcome you to the panel on rural health and well-being in Western Pennsylvania, sponsored by the University of Pittsburgh School of Education. Thank you for being here today. We're looking forward to the conversation. Please know this panel will be recorded and will be later posted on the School of Education's website under the Rural and Community-Based Initiative. After we have our conversation, we have some prepared questions, but at the end, we will have time for Q&A. So if you do have questions, please place those questions in the chat box. I would like to now introduce today's moderator, Dr. Jill Hennon. Dr. Hennon is a professor of biology at the University of Pittsburgh Johnstown campus. Her research examines how infectious disease affect humans and animals, a concept referred to as One Health. Currently, she has a project dealing with similar disparities that occur in access to cancer care in Nigeria and in Appalachia. She has developed a green alternative to DEET to prevent tick bites. She completed her PhD in infectious diseases microbiology from the University of Pittsburgh's Graduate School of Public Health in 2008. She was a postdoctoral fellow in biobehavioral medicine for a year and joined the faculty at Pitt Johnstown in 2009. She's also an advisory board member for the Rural and Community-Based Initiative at the University of Pittsburgh. Dr. Hennon, welcome, and thank you so much for moderating today's panel.
Thank you so much, Dr. Means. I'd like to take this time to introduce our panel and then provide a little bit of information about why we're here. Today, we have three panelists, Dr. Jodrey, Kimberly Roberts, and Mandy Paranish. Dr. Jodrey is an assistant professor in the Division of General Internal Medicine at the University of Pittsburgh School of Medicine. He is certified as an internist and addiction medicine specialist and serves as an attending physician for the Internal Medicine Recovery Engagement Program at UPMC, a primary care clinic, for substance use disorder treatment. His research focuses on identifying barriers to person-centered substance use disorder treatment across the urban and rural communities, and developing, evaluating, and scaling interventions tailored to community needs to improve the health of people who use drugs. His NIH-funded research includes developing a measure of community barriers to medication for opioid use disorder treatment and a multi-site clinical trial of methadone versus a different treatment for opioid use disorder within the office and pharmacy setting. He has developed new partnerships with individuals directly impacted by opioid use disorder, and as a co-founder of the National Coalition of Liberate Methadone, I apologize if that's incorrect, an issue education organization made up of people with lived or living experience of methadone treatment clinicians and researchers. Dr. Jodrey grew up on his family's apple orchard and farm market near Mansfield, Ohio. He and his sister, Anna Jodrey, co-founded the North Central Ohio Harm Reduction Program to improve the health of people who use drugs in Northern Central Ohio. Ms. Kimberly Roberts is an associate director of manages the Community Care Hub. Kimberly is a Pathways Community Hub Institute CHW instructor, certified model trainer, and oversees quality improvement. Kimberly's career includes psychiatric, residential treatment, workforce development, and healthcare management administration. Kimberly is the co-chair of the Cambria County Suicide Prevention Task Force and a member of Hope Beyond Hope Trauma Coalition and a trained suicide prevention instructor. She's a committee member of the PACHW Collaborative. She received a BA in psychology from Indiana University of Pennsylvania and an MSW from the University of Pittsburgh. Miss Mandy Paranish is a Northern Cambria native and boomerang. She enjoys the city energy and people as much as she can, but finds great love and peace and sincerity in her rural community. Her experiences gained while leading healthcare facilities, as well as her education, have led her to utilize evidence-based practices to narrow the spectrum to the needs of those rural communities. It is her goal to meet people where they are, learn where they want to be in their health journey, and get them there. So thank you to our panelists. Now let's give a little bit of background about why we're here. First of all, thank you for joining us. We're all here because we understand that rural health in Pennsylvania is a critical issue due to several factors. One, being geographic isolation. Rural areas often have limited access to healthcare facilities, and providers and therefore compared to their urban centers. This can lead to delays and inadequate care for residents. We also have socioeconomic disparities in our rural communities, and these may face economic challenges such as fewer job opportunities, which can lead to problems in our rural communities. We also sometimes have aging populations. Many rural areas in Western Pennsylvania have a higher proportion of older adults who may have increased healthcare needs and face unique challenges related to aging. If we focus on the rural health and well-being of Western Pennsylvania, there's a good chance that we can improve the overall health outcomes for our residents, reduce our health disparities, and ensure that everyone has access to the care that they need. So, as we're going about our panel today, let's keep in mind that we are all here and all wanting to help our rural communities. So, with that being said, I'd like to start off with our first question. Dr. Jodrey, please answer this question first. I would like you and the other panelists, which will go in order afterwards, to share more about your work, the organization, and how you're addressing to support any kind of rural health and well-being in our community.
And thank you, Dr. Henning, for the introduction, and really thank you for the School of Education for organizing this talk, and just the opportunity to have kind of a rural dedicated space to talk about these things feels really urgent to me. So thank you, everyone. So yeah, I work on the science end of things, which means a lot of my work is on trying to generate new knowledge, and you could say one bucket. I focus, a lot of my research focuses on trying to better understand how the barriers to healthcare, and for me, I focus on opioid use disorder, how the barriers to healthcare may be different across different communities. And in a simple sense, what we're trying to do is better understand what might be the problems getting care in a rural county in Western Pennsylvania versus Allegheny County and urban county, where Pittsburgh is located. And just sort of acknowledging, we all could agree that the way people might access care, the challenges they might face might look very different than in Allegheny County than in a more rural county. And so that's one bucket of my work, is trying to, use different forms of data to help create measures that are easily accessible and allow leaders in healthcare organizations, gives them more information to act on, and to perhaps shine a light on barriers to access that aren't appreciated or understood. And so that's kind of one bucket that I focus on, which is sort of looking at community access to services for opioid use disorder. And then the other piece that I work on is on one particular treatment for opioid use disorder that, in the context of the overdose epidemic, which of course has impacted rural communities in Western Pennsylvania, a lot of my work is focused on examining how to make methadone treatment for opioid use disorder more accessible. And part of the reason to focus on it is that methadone treatment happens to be probably the most effective treatment in terms of preventing overdose deaths. And this comes directly from my experience growing up in North Central Ohio. In many rural communities, methadone just isn't available. So there's a structural inadequacy in the availability of this key healthcare service. And so a lot of my other research focuses on finding ways to make methadone more available, including in places that are not urban. And there's a lot of challenge. We have not solved, I've been working on this for some time now, and we have not solved it yet. But part of it is demonstrating new models. How can we make methadone? How can we have models of care and delivery that work in rural places? And there's of course urgency in this.
Thank you very much. I appreciate that. Ms. Roberts, would you be able to answer that question? Again, share more about your work, organization, and how you're addressing and supporting rural needs.
Thanks, Jill. The Center for Population Health was established to improve health outcomes for the region when some of our primary workers in the community and through the support of the 1889 Foundation recognized that we in our two-county Cambria-Somerset region ranked near the very bottom of health outcomes in the county health rankings. So the two rural communities that we serve, we focus our work on education and community outreach in regard to healthy living, healthy activities, during the pandemic, launching the COVID task force and just ongoing educational programs with Wellness Wednesdays and Walk Works programming, and even a Healthy Congregations Health Ministry initiative. We coordinate the county health needs assessment and hold an annual health summit to talk about our health outcomes and some of the findings from our community health needs assessment. We have a food system coordinator. Recently, we've branched into a lead task force to address high rates of lead in our vulnerable infant, children, and youth community. We work closely with clinical partners to address some of the gaps in care, and we work on policy advocacy to address those community public health needs. Our largest program is the Community Care Hub program. This program is community health workers working through the two county regions. So you can imagine the most rural parts of our community, both in Cambria and Somerset County, our community health workers are working to address care coordination needs throughout those two counties. So we're looking at bridging the gap between the community and healthcare. That's what CHWs do. They're bridging the gap. They're providing that connection. We have the community health workers are doing resource navigation, advocacy, and support, and we do serve those vulnerable pregnant and parenting populations throughout those counties, school district populations with Greater Johnstown and Somerset Area School District, and individuals experiencing mental health or substance use disorders within a behavioral health managed care organization. So we really do run the gamut of services for community health work and care coordination throughout the two-county region.
Thank you. Thank you for that update. And Ms. Piranish, would you give us an answer for how you're working to help the community?
Sure. And thank you, Jill, for the nice introduction. I know that my bio needs a little work, clearly. I'm here today to represent a nonprofit organization called Small Town Hope, which I founded. My work is very undefined, I would say, but very clear in its mission and vision. I started my career as a nurse and worked in wonderful facilities. At the time, I didn't realize how high above the average facilities they were. They were children's hospitals, and one of my favorite places of employment was Johns Hopkins Hospital of Baltimore, of which I spent a good portion of my career this far, and learned a lot about the intra, and post-discharge needs of patients. And I really took a deep dive while earning my master's degree into the disparities of health that existed far outside the lines of critical care. It really caught my interest because I saw those disparities in the town that I grew up in, which is here in Western Pennsylvania. I'm from the Cambria County area. And so about 10 years ago, I just felt the need every time I came home that our community just needed more and more and more of my time. And I don't want to say energy, but just something about being open and listening to the needs of the area. And so Small Town Hope was a way to do that. And so it is an organization, it is a nonprofit, and we really work on uplifting the rural community that surrounds us. We work hand in hand with partners to offer crucial resources now to underserved populations. We really are more pediatric focused, as that was my background as a pediatric nurse and then family nurse practitioner. But what we're finding now is that span of family, we know now involves grandparents raising children. We know that children are raising children. And we know that more than ever, a family isn't as traditional as it used to be. So we pay attention to those things. And our initiatives, like I said, span from the needs of early childhood education all the way up through healthcare and housing support for the Northern Cambria area and beyond that. We really understand that rural health is intertwined with many factors. There's the economic stability, there's the accessibility to care, education. And so we try our best to take a comprehensive, holistic approach to community and health. We do our best currently to offer services that focus on offering education and awareness and screenings, anything that we can kind of nudge into our community, because as we'll talk about later, sometimes those really prominent thoughts or opinions just come from social media, and they don't really come from, a guided expert in any of those things. So what we do is we provide that support. We offer educational workshops, we provide care, we provide education, and we help people get connected to the right providers, even if they aren't in neighboring towns. We have connections to Pittsburgh Children's, we have connections to foundations in the Pittsburgh area, and some in Akron Children's in Cleveland, in the Ohio area as well. But we really just hope to see increased well-being in rural areas and the same level of accessibility that people in more urban areas have, regardless of our geographic barriers. So my work is really to connect those resources to this community and also be the ears and the eyes and kind of the palpable source of information here to, circulate a willingness to help and also a willingness to educate.
And thank you for that. I appreciate everyone taking the time to answer that question. And let's move on to our second question for the panel. This one I would like Kim to answer first, please. What do you believe is the most pressing challenge for rural health and well-being in Western Pennsylvania?
Thanks, Jill. I thought a lot about this question, really just thinking that access is what pops to the top of my mind when I talk about the challenges in our rural communities regarding their health and well-being. We look at 7 priority areas from our community health needs assessment, and almost every bucket of need that we've identified, that the community has identified as pressing for our 2-county region, it all ties back into access to care. So I'll just tell you that with mental and behavioral health, we look at not having enough providers or because of that deficit of providers, long waits perhaps to be seen by maybe a psychiatrist. We look at healthcare, certainly social drivers of health here, SDOH, as you'll hear me maybe refer to them as well, but access to oral health providers in our community. Transportation is huge with our 2-county region. Certainly we know that in the most northern part of Cambria County and for Somerset County, there is limited ability to connect with public transportation, if not none in those regions. We also talk about access to broadband. We would love to say that every person could get connected with telehealth, but I did just hear somebody mention earlier in a call today about, when there is internet, the rural health community health worker can access, that care coordination. So looking at strategies to get that access component for broadband. Obesity and healthy living, we look at access to healthy food. So that's why we have a food systems coordinator, because we know it's a challenge. We look at access to quality, affordable childcare facilities. Mandy has one in Northern Cambria, but I'm sure that if she had capacity to expand that, we would be able to get more folks in there, right? Because we know the needs are great. The access is limited. And certainly we know that childcare ties directly into the ability to get jobs. And so access to positions that are family sustaining. So I'm cheating, I guess, because I'm saying access for all of these things, but truly we need to continue the work that we do to build systems that work for the rural people of our communities. And we're working really hard to make sure that that happens. Our community health workers, through care coordination, are tracking some of the outcomes related to these priority areas. And then when they get that information, and they cannot be successful in completing pathways or connecting a person or a family with the services that they are in need of, that community health worker puts that critical data into our electronic record, and then we're using that information taking it to our community leaders to advocate for system level change, to bring together other folks into the conversation, to build up a community with a system that works. But it definitely is the biggest challenge that we have.
I would agree. As an individual who grew up in a neighboring rural county, Indiana, I can remember it taking me, 45 minutes to get to a grocery store. So access is definitely an issue for our community. Mandy, would you like to comment on what you feel to be the most pressing issue associated with our community?
Sure. It's no surprise. I agree. Accessibility must um, take precedence, I think, for rural communities. And, we can talk about distance and we can talk about geography and the lack of broadband, but there's also a very prominent sense of having the willingness and a good example to overcome that, because we have in the center that we have currently, we have 3 children who require Pittsburgh Children's care, but don't go to their appointments, don't get there because they have to pick and choose. Are the roads okay? Do they have enough money, for gas, for food, for all the things that go along with the trip to Pittsburgh back and forth? And then there's also what do I get out of this visit? If the last visit that they went to resulted in what I would call a good checkup, it almost seems invaluable to some families. And I'm learning that uh, that prevents another visit because it didn't seem worth time or worth energy or worth money. So the accessibility factor is huge. And as Kim touched on, we have a significant decrease of primary care physician in our area just based on age alone. We've had 3 local physicians in the 60 to 80-minute radius all close up shop in the past year. We don't have pediatricians here, so people take their children to family practice doctors. And so the big complaints I hear about accessibility to good healthcare is that the people that their children are seen by now don't know their children. They don't know them. They don't know their grandparents. They don't know anything about them. And every time they go, they see somebody new. So this is very disheartening to a small community. So access to not only the appropriate level of care, but also to a trusted person to care for is also missing from the community I serve. There's also a sense, and I don't want to say it's the most challenging, but there's also a sense of using online platforms to answer their own questions about medicine, of which is really hard because the misinformation is very high. So whether it's about vaccines, treatments, or just the healthcare system itself, a challenge I face very regularly is what's the truth and what isn't? Who do I trust? Who do I not? And I feel like it's unusual. You would think that in a small community, everyone would rely on each other, but there's a lot of uncertainty when they're far apart from each other. There's a lot of curiosity, but not a lot of fact checking. So I think the biggest challenge after 9 years of being here and serving mostly children and their families as their primary care provider is really trying to build trust, to understand why access is getting in their way of getting a better level of health, but also becoming a dependable resource is hard when in a small rural area, there aren't many options. So there's a lot of hardships that go along with that. So I would say that although, transportation and roads and actual money to do that is an issue, I would say accessibility really is limiting, and broadband is a real issue. I'm in Cambria County. I'm surprised I haven't lost connection yet. And I have a wonderful, Wi-Fi that I pay monthly for, but it disconnects. And I see patients through telehealth, and I am often disconnected with them, whether it's on my end or their end. And a lot of patients are hesitant to do telehealth calls because of their information technology, just their lack of awareness on their fear of not operating the computer properly or the speaker properly or the camera properly. It makes them nervous, and they don't, even though it's, just the background behind you, they're nervous about showing all that. So even when we have the telehealth, accessibility can be limiting too. So I'll stick with accessibility like Kim. Thank you.
Thank you for that, Mandy. I definitely have experience with that, thinking that science has its own language. So if our rural residents don't know how to speak that language, they have a difficult time consuming it. So that's an excellent point. Paul, would you care to give us your opinion?
Yeah, so and I'll start by saying agree that limited access to services. There's a history of austerity in rural places, which connects to this idea of why access is so poor. And then I also strongly agree, and that trust is a major challenge. And I guess what I would add to this is to try to sort of connect these things, access, austerity, why we see service austerity in rural places, and why there's a deficit of trust. Some people have invoked this idea of structural urbanism embedded in our healthcare institutions. They're embedded in our large hospital organizations. They're embedded in government, and it's embedded in nonprofits and private actors in the healthcare sector. And what people mean by structural urbanism is that when we talk about healthcare, a urban perspective is assumed. It is normal. It is the default perspective. And that particularly is relevant in terms of power and who gets to make decisions about healthcare. And to kind of put it in very concrete terms, ask yourself, why is there no broadband still in rural places? Why, in the context of the overdose epidemic, the best treatment, methadone, is generally not available in many rural places? Why are maternity wards closing in rural places? Why are community hospitals closing in rural places? And to put it, for each of these things, there are policy decisions, governance decisions, organizational decisions that have been made. And generally speaking, that structural urbanism means is that when it's yes or no, we got to make cuts. It's the rural places that get the short end of the stick. And then so that austerity and that lack of access, though, and this is decades of decision making in the context of healthcare, that has resulted in these disparities of trust. And a lot of I'll just say on this topic of structural urbanism and the deficit of trust, which I think is very important, the thing I would add to this is that when thinking about COVID-19, the COVID-19 vaccine, this is relevant for expanding access to opioid use disorder treatment. A lot of the contemporary focus is on rural places' susceptibility to misinformation, to conspiracy theories. And at face value, there could be some truth in that, but there's also a sort of reinforcing of stereotypes about rural communities, about not being informed, about not being empowered, about not being able to make choices for themselves. And so again, it's that structural urbanism, assuming the othering of rural places. And so I think the part that underlies that is that for many rural communities, that distrust is rational because their entire experience of healthcare has been decisions will be made that leaves them on the short end of the stick. Fewer primary care doctors, a lack of broadband access, a lack of methadone treatment. And so this is a big challenge because there's a twofold part of this. There's repairing those relationships in rural communities, but then there's beginning to address some of these structural antecedents of that trust. And so the bad news probably is that quick fixes are difficult. But that doesn't mean they're not possible. But it means quick fixes are difficult in this setting of rural austerity.
Absolutely. I think it's incredibly important that we continue to remember that rural individuals may have their own point of view, and that kind of point of view must be considered. So thank you for that, panelists. For our last question for this afternoon, let's start with Mandy. What is one resource, one best practice, or one strategy that you would recommend to our audience that could be leveraged to better support our rural health and well-being in Western Pennsylvania?
Well, I thought a lot about this because I couldn't agree more that a quick fix is really hard if it does work, it doesn't work for long here. So I would say the number one resource, the number one strategy, and the number one thing I've had the most success with overcoming some of those barriers here in my community is building relationships with others who do different things in the same, if you will, state and even maybe industry. So it can be local or non-local that can support and connect and create a better line of, I guess, an outcome that aligns with what a patient or what a family or what a child needs. So my recommendation is truly building strong support nets systems. And that's the main reason I wanted to join this call today, because an example of that happened to me yesterday. An employee of my nonprofit organization had a hardship. And if it wasn't for our connections to I would say our friendly peer organizations, I wouldn't have come to a resolution for her hardship as quick as I did without it. So our nonprofit started as a small building, a bright small blue building. And under that roof, it was a couple educators, a couple nurse practitioners, and a couple people who were looking to make a difference. And today, 9 years later, there are several foundations, several organizations, several other experts in their industries that all leverage their interest in helping, but also their knowledge and expertise to really make ends meet. And I think when you have a number to call, or you have an idea in your head who would know how to help you, or even if you don't know who, but you know that someone would be interested in helping you, it gives you a sense of strength. And then that sense of strength trickles down into trust for your patients, for, families, kids. So my recommendation is building those partnerships from the get-go, not trying to come up with a quick fix. And my other recommendation for rural health and building those bridges is to do what you say and say what you do. I feel like in rural areas, people count on that. When you tell them that this is going to happen, be sure it is. And if it's not going to happen, don't paint a picture that isn't true. I have type 1 diabetics in our center who I argue relentlessly with their parents that although their blood sugars are okay, they still need to go to their doctor's appointments. And I have to explain why, because if not, they feel that as long as things are okay, we don't have to go. And so being consistent with the truth with our population, but also not painting anything that isn't, a reality for them is vital. So I guess my recommendations are for anyone listening, whether you're in a nonprofit or you're a care provider or you're totally opposite, is that rural communities need people of all backgrounds, of all experiences, of all walks of life, because it does take a village, and nothing beats someone who wants to truly help and is going to tell the truth while they do it. So that would be my advice.
Thank you. I think that was excellent advice, and I appreciate you offering it for us. Paul, would you care to give your recommendations?
Yes. And so, so what do we do to address, structural urbanism and how it's embedded in, our healthcare organizations, our healthcare systems? It's a big challenge. And then intertwined with that is this deficit of trust and relationship building. And I agree with some of the things that were just said. It's part of this is healthcare organizations following through on meeting their obligations with rural communities. If we say X, we need to do X, and we need to be, we need to show that rural places are a priority. The other thing I guess a key challenge, and I feel this is across the board, across organizations, I'm on the science end of things, but this is for every step of the way, with front end service delivery, community organizing, startups, nonprofits. We need to think about representation. Part of addressing structural urbanism means making sure we're deliberate about having the rural perspective at the table when decisions are made across organizations, and being really deliberate about inviting rural people from that perspective at the table so that they're included in decision making. And that in itself, symbolically, and then both in the act, symbolically, but then also in the decisions that are made, are going to result in decisions that are more rural centered. And, I think one thing that's real important, and this relates directly, education and healthcare intersect so much. Credentialism is often a big barrier for that, including rural people at the table when we're making decisions. And I can give you, there's lots of examples of this. I'll give you one from my world. I study, treatment for opioid use disorder, and Suboxone, buprenorphine, that B word Dr. Henning mentioned in my intro. It's it's a good treatment for opioid use disorder. It prevents overdose deaths. When the original policy was passed, it was limited, the physicians it was the ability to prescribe buprenorphine for opioid use disorder was limited to physicians only, to MDs and DOs. And that immediately, that requirement, well intended, right? The idea was we want well-trained providers offering buprenorphine. Well, in rural places, they're much more reliant on nurse practitioners, advanced practice providers to meet the needs of their community. And so again, there was this structural barrier to expanding a key treatment. And it was credentialism in this case. Often we need to acknowledge that the type of talent, the way talent gets recognized in rural communities, they may not be able to attain the same amount of letters behind their name, but they have immense talent and knowledge of their local communities. And so we need representation. We need ways to bring rural people to the table, overcome credentialism, and include them in decision making.
Thank you for that. It sounds like you're paraphrasing Ruth Bader Ginsburg, essentially saying that rural people or rural individuals belong in all of the places where their decisions are being made. Thank you. So I appreciate all of you and the time that you've taken to answer our questions, along with the questions that we have discussed. And Kim, we have you next with your perspective.
Thank you. It took so much for me not to be applauding and snapping to what was just said. And I think that our strategy here at the center is really to look at that collaboration to amplify the strength of our community organizations by supporting partnerships through the pooling of ideas and resources and looking at system level problems together. We do have a community advisory committee that gives voice to representation from our communities, which I think that is the only way that we move forward together, is to get direct input and feedback from the folks that are living that truth, right? Having those experiences. Here at the center, we really strategize for a willingness and desire to work together, but we're not waiting for those opportunities to arrive. We're going out with intention to lift up our communities through our shared work. We are proud to make introductions, facilitate meetings, work together to address those broader needs. Our goal is to break down those silos, supporting organizations to support each other. That happens a lot. There's a little bit of, can be at times, folks that kind of get in their isolated boxes and just kind of keep doing what they're doing. But we strive to create some ecosystems of care, cultivating conditions that allow people to flourish and communities to thrive. We can't do that instantaneously, although we wish we could. We always say it is a marathon, not a race when it comes to population health change, but we really do strive to create opportunities across the two counties and beyond. Truly, we've had opportunities to tap in. I think Jill mentioned the Indiana County. There, we're all in this region together, and we really want to be the community unifier and the community convener, bringing together some of that system level change that we know is critical. Just for our health outcomes to improve. It's really the name of the game. We are all in this together, and we want to move forward in such a robust way that the folks in our community can live long, happy, healthy lives.
Thank you for that, Kimberly. So now we have some time for some questions from our audience, and there are a few questions to go through. So I'll start with you, Kimberly, because I think this question best fits your organization. what steps are being taken to address racial disparities in mortality in Cambria County?
Thanks. Well, we focus on birth outcomes because at the time of the launch of our community care hub, it was recognized that Cambria County had the lowest birth weight and unhealthy birth outcomes in the state of Pennsylvania. We recognize that as part of that, our Black and African American birth weights were lower, and statistically, on a national level, they are also lower. And that is how the Community Care Hub model, the Pathway Community Hub Institute model, was started to really to address the health disparities in our communities. And a lot of that through access and connection. We work very hard closely with our clinical OB providers to make sure that our birth outcomes are robust and they are healthy. And we can say that we have had great success meeting the needs of those birth outcomes. We do focus on that as a model. That is one way that we address the population health of our community. We know that when babies are born healthy, that makes healthier communities in the long run. So I would say that is our best approach to serve our communities in the most robust way.
And Mandy, how do you see that playing out in the northern part of Cambria County, which by definition is significantly more rural than the southern part of Cambria County? So how is your organization working to address any kind of racial disparities that you see?
Our demographic is very typical of a rural area in Western Pennsylvania. We at our center currently, I would say it's like 90 to 94% white, born here, raised here, related to here, out of probably 800 people that we intervene with on a weekly basis that way. We only have a very small population of other minorities here. And so among it being a minority, there's minorities within the minorities. And what we do our best to talk about it, to make it a okay thing to talk about, welcoming parents of a minority to our center earlier to talk about why they don't like the kind of food that we had the day before, or inviting them in to tell us about what was good and what wasn't good about their interactions, from language to food to interactions to clothing. It's all relative, cultural, and it's all relative to care, and it all needs its attention. So I think from my organization, the racial disparity here and the gap that we see is small, but it has our highest level of interest because we do value it. We don't want to mess it up, not because we're afraid of any outcomes per se, because we are just providing, education screenings and those items, but the way we do that matters. And if we aren't in tune with it being a good fit, then we miss the opportunity altogether. So I think just giving it the attention it needs, and it needs a lot more attention than what we assume, and embracing that a lot of the providers I work with and educators I work with are afraid and are a little timid to get involved with that. They don't want to screw up. They don't want to make anything sound bad, look bad, or give the wrong impression. So I think just drawing attention to it and talking about it with our small population of minority, whether it's religion, race, gender, any of those things, really has been helpful on our end.
Thank you. Paul, do you see anything in your research that pertains to Cambria County specifically, or is your research more generally all rural communities?
Yeah, I have, so the short answer is we could. So I have just off the top of my head, I haven't drilled down on what, some of the measures I developed are national, but it would include Cambria County. And so, off the top of my head, I wouldn't, what would be interesting is to see what our measures might say about here's where Cambria lands, and then here's how surrounding counties may compare. And so part of what my science does is try to make those comparisons more accessible to a wider audience, to allow more people to be able to have information to make those comparisons and to say, hey, here's where Cambria County might be doing well. Here's where it might not be doing well compared to surrounding counties. So we are trying to make answering those questions easier.
Well, that is a great appreciation. And while I have you, I've got a follow-up question for you. How can we approach healthcare access in emergency settings in rural areas?
Yeah, it's a really good question. And again, part of this is acknowledging that we face tough headwinds for these structural reasons we've talked about because of rural austerity, a lack of trust. I think you could think about some buckets. You could start by thinking about the services your emergency providing organizations may offer, and do they offer services that are accommodating to people, to barriers that might be more present among rural people. Do they try to make telehealth options as accessible as possible? Do they factor in transportation and transportation burden, in their services and decision making? And so, I think there's sort of you could think about, reviewing your services and making them as accommodating to rural people as possible. But I think kind of coming back to some of the things I said earlier, upstream, even before that, and to do that accommodation of your service as well. Thinking about how does your organization make decisions? Who's a part of those decisions? And how could you take steps to make sure rural people are at the table when decisions are made? Do you have an advisory board? Do you have a board of governance? What community, engagement does your organization pursue? And when you do it, are you deliberate about including rural perspectives or people who are historically disenfranchised? And then an important piece of this, and this connects back to some of the other things that have been discussed. It can't just be a PR, board. It can't just be, hey, we had some rural people here in March, and then, if you're going to invite people, it must be meaningful, and their input must be meaningfully impact decisions. It doesn't mean they get every wish they ask for, but it must be meaningful. And so these things have to be done carefully. It kind of connects to earlier mentions of, like, if you're going to say something, if you're going to say you're going to do it, you got to go do it. And so being very deliberate about that relation building, inviting people into places in your organization where rural people can have input into decision making. From that, you can learn how to tailor your emergency services to the actual needs. You get those needs directly from the people you're trying to help.
Thank you for that. Mandy, does your organization deal with any kind of healthcare access in emergency settings in rural situations?
Yes, and in a not from a nurse practitioner standpoint, but from a if and then standpoint. So we work very closely with our local emergency system. So EMTs, fire, all of the local people who are, many of them volunteer, working to really communicate strongly what our community needs. And I'll put it very vaguely, if you need stitches, can we do that here? At Little Miners Medical Center in Hastings, can we do that here? And we make sure that we communicate that across the board. Not only can we do that here, but we do a good job of that here. And then we stand by that. If you have pain in your abdomen and you think it's your appendix, they can do that here. They can do that here, but also being very clear about that there is ways out of here too. When things are bad, when these signs and symptoms come up that are warnings or indicative of something bigger, you got to get out of here if you want to get better. So how do we make sure that's communicated? And I think in a rural community, the communication of if then and helping people understand what is here and what is good here and what, you better plan on packing a bag. Making that upfront before it happens, we find great success with. So we partner very closely with, every fire company around here is like our best friends. It's Fire Prevention Month. They're all at our daycare and they're all at our preschool and they're having a good week. But the message they're sending is, this is what you go to the hospital for. This is what you call us for. This is what you go to eye care for. And I find that very rewarding for families because although your questions about the emergency settings, there's blurriness now with the eye cares involved and also who comes when you call 911 and where are they going to take you? Because now it's not just where are they going to take you, but people are really concerned about, are they going to take me where they accept my insurance? Does my insurance cover this? How much do I need to pay to go there? I was in example. I was in a fender bender on my way to work this morning, Mandy, and they asked me if I was okay, and I was, but should I have gone? Will my insurance cover that? So bringing that into our organization and talking about it out loud and making sure everybody knows who's employed by Small Town Hope, when accidents happen, these are good steps to keep in mind. I feel like that answers a lot more and builds a stronger foundation of how to, with if and then statements rather than, dealing with it in the moment. So I think emergencies in rural areas, I mean, I grew up here. I have stitches all through my face, all through my body. They did a great job putting me back together. And I will speak highly of the emergency systems here, but I also know that it helps that my mom and dad knew what to do when the time came. So I hope to do that for other families and kids in our area.
It sounds like it would be great if we could have a little thing that people could carry in their wallets in rural communities. And then like an ID bracelet that we have for, medical alert systems, if we could have something like that that could just hand and that kind of an issue. We do have one more question, which I'm going to give to Kimberly. What is an initiative that you've worked on that has been significant in addressing health inequities in Western Pennsylvania?
So truly, the community health worker model of care is one that addresses health inequities through building trusted relationships in the community. Community health workers have a shared geography with the people that they serve. They have lived experience or cultural, racial, or ethnic backgrounds that are similar to the people that are served in our program. They may share the same language. So we really drill down on that health inequity piece through building up folks in our community. I think nothing about us without us, kind of captures what the community health workers are doing across our region and across the state in Pennsylvania. It's a growing workforce. But I think it is the key to say, hey, when we're approaching healthcare, my community health worker might look like me, or my healthcare provider, has the same language as me, and creating those spaces where we are lifting up folks in our community to have that equitable access to care. I think making sure that people are given opportunities to advance in their own career, so they get into the fields, so that they can, make that impact and that difference. It's why we live here. Mandy referenced growing up in small town. I grew up in Somerset County, very rurally. That's why I live here. I love where we live, and it is special, and it is different, and it's meaningful. So I think creating more of those opportunities universally for folks to have that equitable healthcare.
Well, thank you for that. And I would like to thank all of our panelists for being a part of this webinar. Tonight, we have heard from 3 accomplished panelists who work to help connect rural communities to the healthcare infrastructure that they need. Paul is working towards bringing treatment to those who have experienced substance abuse disorder. Kimberly with the Center for Population Health, working to create access in our communities, and Mandy to work for the betterment of children in Western Pennsylvania. What I gathered from this webinar was the prevailing theme of the afternoon is that we need to work on understanding the rural individual's point of view, building trust in our rural communities, and increasing healthcare infrastructure to make something economically viable and humanly meaningful. So we got to work on those 2 types of solutions. If we bring rural people into the discussion, then we can work and help to make them a part of the process. So I'd like to thank you all, and if you would like to say one last closing remark about what you thought the theme of the afternoon was, we'll start with Kimberly.
So truly, I think shining a light on the unique needs of rural communities is so important. I think Paul spoke to it earlier. We tend to, and when you said that about thinking about a hospital and you think about that urban, I'm like, oh yeah, you kind of do. And so really taking that step back, pulling back the lens and looking at this to include all of our people in our communities. It's a critical part of what we do. We've got a strong history here. We need to support and create systems of care that work for everybody in it. So,
Mandy?
myself. Sorry about that. I think I agree that the dominant sense is that the rural community has needs of its own, and it's okay to say that. And I think from learning a lot and spending a lot of time in the urban setting and now being back to rural, it's okay and it's not bad. But you have to give it the time it needs. It's almost like its own population in a sense. And when you say you should be at the table, I couldn't agree more. Being in early childhood education as a service line that we offer, I often don't get welcomed as a nurse practitioner to that table, because what do I know about, a daycare or preschool environment? But man, it's like, how can we not have that crossroads? How does the Department of Health not work with the Department of Human Services so that the children at daycares are healthy? So I think rural is a population to be identified and to be treated as such. And I think that the panelists on the board and all that went into this, brief meeting, I feel like we're finally starting to get rolling and we're done. But I hope to see more of that in the future, because I think there's a good network of people in these areas that are doing really good work. And if we could work together, I think the outcomes would be better.
And Paul?
Yeah, I agree with what's just been said, and I'm really just appreciative for the team that organized this panel. There's just a simple need for more discussion about things from a rural perspective, and having spaces that are explicitly rural to create the opportunity to talk about these things. I mean, part of the reason why sometimes it can feel like a revelation to do this is because there just are so few places in a very credentialed places that these healthcare institutions are. There's so much credentialism. There's very few opportunities to just talk openly about these rural issues. And so, one of the first simple steps is just creating more places to talk about it. And so really grateful for this opportunity and grateful to participate.
Well, thank you all, and we would like to thank the University of Pittsburgh's Department of Education for organizing this webinar series, or this webinar, and we are all grateful that those of you that are in attendance have stayed on, and we hope that we can continue to build back rural and bring those individuals to the community. Thank you.